Our final speaker of this session is Lisa Ridgway, who is also a patient partner. She donated hematopoietic stem cells to her brother on 2 occasions. And her special interest, trying to keep to the same format of introducing the speakers, is in patient-orientated research and mental health, so quite a broad spectrum of interests. Her background is that she's a lawyer by profession, but I think is therefore in a very good position to act as an advocate in terms of being at large and in regard, specifically in regard to patient and donor engagement. Thank you.
Thank you so much. I'm not Tim Caulfield, so I can't quite end on the note that he did, but I'll give it a go, as they say in Australia. Thank you, Paul and Karen, for inviting me. Thank you for sticking it out. Please try and stick with me, and I will try and stick with me too. Obviously, I'm the second patient partner, a very new one, and it's a tremendous thing to hold the torch up with David Sweet and to meet giants like Dr. Sherwood and Dr. Kim. I called my talk a journey unlike any other for a good reason. There are 1 or 2 people in the room here, Louisa and Shazad, who have heard little bits of it. I've spoken at 4 conferences in the last 3 weeks, different speeches, of course. And every journey starts with a step, and this is mine. I'm stepping out, as it were. I don't have slides. In my old profession, we don't use slides or blackboards or PowerPoint. We use words, so please lend me your ears. To use an old phrase, I am Lisa Ridgway, and I am a recovering lawyer. Yes, and also recovered from major depressive disorder and a stem cell transplant donor, 12 out of 12 HLA match. So back to the law. One day as a very new lawyer, I stood in a public courtroom full of senior partners who were making up their minds to hire me, and I had a really good argument, and the judge saw my quaking hands and said, Miss Ridgway, I've read your argument and it's fine, but what is its weakest point? And I wanted to say, of course, well, there are none, Your Honor, but I didn't. I bit down hard and I said, thank you for raising that question. And glancing to the other lawyer, the plaintiff's lawyer, I said, my learned friend, because that's what you call lawyers in court, at least here in Canada. Even if you can't stand the other lawyer, you always say, my learned friend. My learned friend has raised an excellent new point of law in a very proleptic way. Well, of course, I didn't actually say that, but I kept a hold of the legal ball and I fell over the finish line and I won the case. So what is the weakest link in my appearance today? Well, Your Honors, I'm the new kid on the block. There have been other patient partners on this team. Mary, I'm very sad I never got the chance to know her. And I've met some of the team in the last 24 hours. Great dinner last night. Thank you for your hospitality. I'm not really an exact match to use the language of this project, but I'm a living donor, and it was blood cancer, and the recipient died, and so did I, in a way. These days, I speak slowly, I write slowly, I even try to drive slowly. Direction is better than speed, right? So sometimes I can't help but hit the gas, and I hit the gas when Paul asked me to join the team. What an honor, what a privilege to join people like David and Karen and James and Paul and Sari and Andre. Now that is something. Why do I speak slowly? Because every minute counts, like the minutes I spent on a plane going back and forth to Australia, because that's where the recipient lived, my brother Mark. So do I have to tell you about the preparation, the medical preparation in 2 countries, the psychological preparation, the physical journey, arriving weeks before the transplant, pumping myself full of drugs, GCSF to stimulate the migration of stem cells from the bones to the blood. Man, did that ever hurt. And then there was the travel insurance company that refused to provide me with travel insurance because they called it a voluntary assumption of risk, as if being a bone marrow transplant donor was a choice. And then there was the transplant surgeon who said, you know, once I had landed in Australia, I'm not really your doctor, I'm Mark's doctor, so the first duty is to him. Did you have any unprotected sex at any time in your life? Like, are you on any antivirals? So I looked at him and I thought, unprotected sex? Are you kidding? I was 16 and blonde. Like, of course, but I said, no, I mean, not intentionally anyways. So going back in time, it was a 30-hour trip. I did it twice. Australia's finest transplant hospital just outside of Sydney called Westmead, 2 transplants, 2 lymphocyte donations. I was the only overnight patient on the transplant ward twice. Once I made the journey knowing that it would work to keep my brother alive, and once the second time knowing it probably wouldn't. So 60 hours of being in an airplane seat every second, every minute. And yes, I really am being dramatic. To instill the patient experience into this project, it does take drama. And drama isn't empirical evidence or quantitative measurement, but it is real life. Now someone once told me that experience sometimes lasts like a minute or a second, and how you deal with that experience lasts a lifetime. And in my lifespan, the journey, unlike any other, ended well. I mean, I'm here today. For my brother, not so much. Diagnosed with non-Hodgkin's lymphoma, 9 years. 9 years. The transplant process twice. The process itself worked very well, but the outcome did not. Mark died. Graft versus host disease played a terrible role. He had just been through so much trauma. And my parents, of course, having 2 children in a transplant ward, that's trauma. I always followed Mark around. I was like a happy puppy. What a bother I must have been. And then I wasn't a bother anymore. He went off on a new adventure after getting his doctorate, went to teach and establish a lab at Australia's National University. He helped design the Australian synchrotron. I got a law degree and went into an esoteric area of law that involved big cases like whether or not our client, a small insurance company called Lloyd's of London, had a duty to defend people like Conrad Black, among others. So I did well, and I helped the Lloyd's syndicates keep lots of money. Anyways, getting back to my relationship with my brother, I was a bother at first, and then I became his friend as adults, and then I was his donor, and then I gave the eulogy at his funeral. So after Mark passed away, I was diagnosed with depression. Treatment-resistant depression was how we used to call it. We now call it major depressive disorder. I was not well, I was suicidal. I spent 10 months at a hospital as a day patient, but I got connected very quickly to a really good psychiatrist, Dr. Wei-Yi Song of Island Health, distinguished lifetime fellow of the Canadian and the American Psychiatrist Association. He signed me up in 2017 for an innovative trial called RTMS, repetitive transcranial magnetic stimulation. I was taking a lot of antidepressants. The trial didn't work. I paid $1,000 for a PGX test from a company called Genomind. Dr. Song looked at the results and said they were gibberish. So I tried exercise, diet, psychotherapy. Some things worked. I was patient 0 for a full ketamine treatment at Island Health, trialed and failed antidepressants, took lithium for a year or 2. Dr. Song would not give up, and Dr. Song's perseverance saved my life. In a very bold move, he reached out to a professor at the University of Victoria, Dr. Hector Carrancho, a CIHR chair in neuroscience, and something really clicked when I met Hector. He wanted a patient partner for a CIHR grant So I went to his lab at UVic, Division of Medical Sciences, soon to be the Faculty of Health. And Hector does work in blood biomarkers for depression. I became his patient partner. I help him and his team understand the human side of depression. That was 7 years ago. Hector and I have co-published a number of articles. We just got a new big grant. I'll be working here at Royal Columbia. I haven't looked at the NDA, but it's a pretty big grant. Then I met another professor at UBC, Dr. Fidel Villa Rodriguez. I have an ongoing role with him, an appointment at his lab, the Ninette lab in the Department of Psychiatry at UBC since 2019. We just got another big grant together. I mean, not big like big, but big enough. We've published some papers as well. So I do help. This is what the patient partner can do on teams. Thank you, Dean. We can bring money in from federal and provincial and private sponsors and sources. And somehow over the years since Mark's death, I have become a research ambassador of sorts for patient-oriented, not patient-centered, but patient-oriented research under the federal strategy parallel to the CIHR called Canada's Strategy for Patient-Oriented Research. I'm on about 6 research projects now, all of them, except this one actually, but maybe this one too, to do with mental illness. I think I've been about 20 or so in the last 7 or 8 years. PGX for mental illness, RTMS for mental illness, many different projects for mental health, many papers. This is a busy time of year. I'm in the midst of writing another paper right now for Facets, Canada's Royal Academy of Science Journal. They asked me to do that. I'm getting there. I'm almost done. I consult with Island Health, with the province nationally to do with research policy and patient engagement, particularly in research involving mental illness. A lot of committee work and a lot of conferences. In fact, I was just the co-chair at a conference for 450 people in Vancouver 2 weeks ago. So I think getting involved in research actually saved my life. But this particular project is about a journey in patient engagement to do with PGX. And with Louisa and Shazad, I'm doing a project to do with the implementation of genetic testing to treat depression. And we just finished a 4-day public deliberation. We're in phase 2, like this project, many millions of dollars and much at stake. What a journey. And there's been drama and emotion. So I know a little bit about pharmacogenomics. I mean, not the difference between mitochondrial and chromosomal DNA, but I'm trying, but that's what this good team is for. So stick with me here. I'm going to posit a theory about patient engagement in pharmacogenomics or in research generally. I've just thought of it. It's something akin to drama called emotional involvement in research. It can be cathartic for a patient partner to join a team, to replay or relive the experience so that others on the research team can really appreciate what it's like to be a patient and to help ensure that the lived experience is not forgotten and to ultimately change the course of medical practice so that other patients don't have to go through your experience, or perhaps just so that others learn that there can be another way forward. So that's emotional involvement. Let's call it EI, not emotional intelligence, some of that too, but emotional involvement. There are very groundbreaking papers out there. It's very au courant, but that's the first part of the equation. The second part of the equation is scientific method. In other words, the rigorous evidentiary accumulation of fact leading to a conclusion, the testing of hypotheses, developing hard and hopefully implementable science. So if you add emotional involvement and scientific method together, you know what you get? You get a patient partner in research. That's what I am. I am a mixture of emotional involvement, knowledge, and a vast appreciation for the science involved. Because you know what patient partners give They give to a team something that can't be measured. We give you what happened when we took the pills, when we or other patients nearly gave up, when we were hurt. And we still hurt because if you are a patient partner right now on a research team, you know that sometimes it hurts. So when Paul asked me to join this mighty team, I asked myself, what could I possibly give to a project so advanced, so complex, so immense? What could I possibly add? I'm 110 pounds soaking wet. But perhaps I could add a wry sense of humor. Or perhaps I could add fashion advice, I don't know. Then I got it. I know what I could add. I could add a singular sense of fury. Quiet fury. Because I am still mad at the world because of what happened to my brother. I really am. I'm mad because I will never get the chance to sip another glass of Australian Merlot with him and lean over a paddock fence and look at the sky and laugh at an obscure memory like, hey, Mark, remember that time we went to New York City together, just us two teenagers? What were my parents thinking letting us go? And then you went out, Mark, and you found that restaurant called Ridgway's. And we went in and you said, try this. And you handed me a rye and ginger. We were so young then, what a laugh. Now, if I can harness that sense of quiet fury and injustice and help in whatever way I can on this team, I will. Because I don't want that horrible thing called graft versus host disease to happen to anyone else. So I guess you could say, in a way, I am my brother's keeper. I was his donor twice, and he died. But I keep him alive through research like this. And it's a journey unlike any other. And thank you for letting me be a part of your journey today, the journey on the path to tolerance. Thank you. Oh, I forgot to acknowledge my team. I don't have a picture of them, but I have a husband and a dog called Dazzle, and that is my funding disclosure and my team. Yes. Yes.
I put it out to the group. I asked you that question yesterday because I was personally struggling with that. So I was on a grant panel where there was a patient partner.
Yes.
And we both reviewed a grant. And I have to disclose that I get money from industry and everything as my conflicts of interest. But as it turned out, the patient was suffering from the disease where the grant tried to solve.
Yes. Yes.
And I didn't dare to ask in that scenario, essentially. And the patient was heavily advocating for the grant. And I thought it was the worst grant in my whole career I reviewed. And I was not sure how to handle that relationship.
Yes.
So I would like to hear your perspective. Right? When we talk about science, often the conflict is that
yes.
I understand your motivation, sadly as it is. And then you meet somebody like me who says, well, that's the wrong science, right? That's not important. And then it becomes quickly controversial.
Yeah, it's a
so
great
what
question.
can we learn from each other to work through such a scenario? That's what I don't know whether it fits
No, it's
here.
a great
It's more
question.
generic. Yeah.
No, it's a great question. The conflict of interest issue, am I going to be on a research team as a patient partner and push because I want that cure personally, or I want it for, my friends who are also suffering. As a lawyer, I guess I'm a bit more trained rigorously to put up the boundaries between profession and person, because if you take on your client's dramas, then you can't provide the distance that it takes to be an effective advocate. Happily, I no longer suffer from treatment-resistant depression, so I don't even have to use that equation because I stopped taking my antidepressants. I didn't tell Dr. Song. It's a bit of a drama. I wouldn't recommend it. He would have said, and he did say, we could have titrated you off, and I said, no, I'm just going to stop. So happily, I don't have to make that sort of choice anymore, but it is an ongoing issue. You made me think yesterday, you're making me think now, and we can talk more about it, but I thank you for the question. Thank you. Great, thank you.